can positively say that I have one of the longest experience in use of anti-obesity drugs for the past 45 years. Any of these drugs came and just disappeared like that because of the side effect. The last one to go like that was isomeride, which was the brand name Leptos, which was prolifically used about say 20 years back. It simply disappeared because a mild increase in the systolic blood pressure by 2 millimeter and diastolic by 1 millimeter. The drug was discontinued. As regard to the newer drug which was coming, today I read in the journal that use of semaglutide increased the occurrence of age-related macular degeneration, that is visual impairment. Today only I read it, by about 1.2%, especially on long-term use of the drug. So when you are using this is with regard to semaglutide. So when you are using this drug, you should be very cautious for any side effect and report it so that it will be analyzed whether these side effects are only by chance or is because of the real occurrence.
I would say the SELECT trial using semaglutide was the most impactful cardiovascular trial in this decade, because if you are implementing the recommendation, all our patients, 50% of the patients, the body BMI was more than 27 only. So most patients which come to our OP, their body weight is 27, BMI. So all these patients qualify for treatment with an injectable semaglutide. We don't know about the oral semaglutide in this scenario. Second point is the 16% discontinuation rate with the injectable semaglutide there, and our patients vomiting, nausea, GI. So our patients have zero tolerance to nausea and vomiting. So how do you think that our patients will accept? Because we will have to start writing this based upon this randomized control, well-conducted randomized control trial to all our most patients with a body mass index more than 27, which is the case in most of our patients.
Oral semaglutide, one point. Oral semaglutide also, now we have outcome data. It is showing reduction in cardiovascular outcomes. But no serious side effects. It may be sporadic cases, what Dr. Muralidharan has pointed out, but no serious side effect in the follow-up of 5 years. Now this is first cardiovascular outcome trial came in 2016. Now it's around 9 years. No serious side effect, but you should avoid that in those patients who are having multiple endocrine tumors because of the risk of medullary carcinoma in rodents. Then sporadic cases, but no serious. But most important problem is GI side effect. So in real world scenario, it may be high, but it gradually fades. So patient will reduce the intake of food, they reduce the appetite, but they have GI side effects. But in these trials, the percentage of stopping this drug was around 4 to 5%.
The semaglutide injectable, the discontinuation rate was 16%. 16.
I have one doubt. Actually, by the mechanism or due to the side effect, this GLP-1 receptor agonist has less lean mass volume. So that will also reflect in the body mass index. So always those patients we are giving GLP-1 receptor agonist, we should emphasize on exercise. Otherwise, the BMI will reduce, but that's partly because of the muscle mass loss also. So that's not on this fat percentage. Second point, a question to actually we should start finerenone only after maximum tolerable level of ACE-ARB, or just we can start with the criteria alone?
In these trials, they have started finerenone after the maximum dose of this. Also, KDIGO also suggests after maximum RAS inhibition only, you can start on finerenone. This is a class 2A indication. After RAS, if there is still EGFR decline and albuminuria is not coming down, you can start finerenone.
Okay, thank you.
Dr. Shavin, is there any recommendation for potassium monitoring? How frequently?
Actually, after starting, 4 weeks after starting, you have to check potassium. Then if it is more than 5.5, you can stop. If it is between 4.8 and 5.5, you can continue the same dose. If it is otherwise, you can continue the same dose. initial after starting 4 weeks you have to monitor them. Then they say that according to the patient characteristics, then you have to monitor the potassium.
Oral semaglutide has memory effect, whether it is beneficial or otherwise. One thing to watch out for when you take that is you have to have enhanced intake of proteins. Plus, you should have exercise, preferably power exercise. Otherwise, you will lose muscle mass and go into sarcopenia, along with weight loss.
I think the excess concern about sarcopenia is unfounded, especially in tirzepatide. Tirzepatide 75 to 80% is fat loss. It's not muscle loss. So now we don't need to be worried much about the muscle.
Is there any long term? Is there any rebound increase?
We don't have that much long term data. We have data for 5 years.
In 5 years, after a few months, does the weight?
But they have to continue that. We don't know how long they have to continue. Once they stop, there is a chance that it can regain.
There is some legacy effect, but it will be
Just a couple of days ago, I was listening to a bariatric surgeon in Delhi. It was an ADA auspicious meeting about obesity. So this gentleman was saying, all these days, the drugs, whatever anti-obesity drugs, reduced by 10%, 15%, whereas bariatric surgery was from 20 to 40%. So for the first time, we have a drug, tirzepatide, which has crossed that level and reached 22 to 25%. But what he was saying was Dr. Sibu's point. He was saying that bariatric surgery actually resets the hypothalamus so that you don't gain any more weight. That is, weight is set at that level. Whereas these drugs do not reset. So if you stop the drug, you will again increase the weight. I don't know how correct it is, but that is what it is.
That is true with diabetes, hypertension,
Yeah.
but every chronic
Every
chronic disease, people have an urgent. If you stop, you will regain. It has to happen.
No, there is data that tirzepatide, when you stop the drug, within a period of 6 months to 1 year, you regain 30% of the weight loss. That will be coming back. The only thing where lost weight does not come back is bariatric surgery, where it does not come back.
Because it is a permanent thing.
It is a permanent thing. Of course, you have to accept it.
Reset.
Because what he was saying is stomach is a very distensible organ. So even if you do a sleeve resection, stomach will increase in size over the years. As you increase in your intake, stomach will also increase. But still weight does not gain. I don't know.
Anyway, I think the time is over, but we have to conclude that these two drugs are wonderful type of drugs with future, anti-obesity drug with cardiovascular outcome data, and finerenone, which now better recommended for kidney disease and diabetes. Probably it will come in heart failure also. So with that, congratulations to Bino and Shaveen for excellent discussion on these two topics.